To all who are new here, my name is Dr. Michelle Henney, and I'd like to welcome you to Releve Sports Medicine's virtual journal club. We are looking for an athletic trainer to join our team. It's a combined position working in a sports medicine clinic and at an NAIA university. Please feel free to pass our information along if you know of a qualified candidate. More information regarding applying can be found on our website. For additional webinar educational opportunities, you can visit our website and register directly for the webinar or sign up for the email list to be notified of upcoming webinars. We are continuing to update our schedule, so check back often. For all athletic trainers who are intending to get live CEUs from the BOC, you will receive an email 1 hour after the webinar concludes, which includes a link to the combined quiz evaluation and assessment. You will have up to 72 hours to complete the quiz and the evaluation. This email will come from customercare@gotowebinar.com. Please ensure that this is done to receive your statement of credit. If you don't receive the follow-up email or you have any other concerns, then contact us via our email at journalclub@relevesportsmedicine.com. Once the statement of credit is available for download from our website, you will receive an email notification. If you have any questions during the webinar, please submit the question and we will review questions at the conclusion of the presentation. If you cannot see the PowerPoint slides and you're accessing the webinar from your mobile phone, swipe the screen to the left or to the right and the slides will become visible. The recording will be available for review from our website tomorrow. Our speaker this evening is Dr. Erica Marshall. Erica is entering her second year as an assistant professor of exercise science at Florida Southern College. She received her PhD in exercise physiology from Kent State University in spring of 2020. Her primary research interests include understanding the vascular effects of resistance exercise modalities, specifically changes in large artery stiffness and heart rate variability. Her knowledge of exercise spans academia. She is truly passionate about exercise and genuinely interested in motivating others to prioritize their health and adopt a physically active lifestyle. She has worked as a personal trainer, strength coach, and group exercise instructor. Erica is a certified strength and conditioning specialist through the National Strength and Conditioning Association, the American College of Sports Medicine Certified Exercise Physiologist, and American Red Cross First Aid CPR and AED Instructor. Let her take it away.
Thanks, Michelle. Thank you for having me tonight. So again, I'm going to be discussing heart rate variability and hopefully give you a practical approach to using it from a sports rehab perspective. So again, just a conflict of interest statement before we start. I don't have any financial relationships to disclose, and I will not be discussing any products in this presentation. So just an overview of what we're going to do over the next hour. I'm going to start with a little bit of background information on how the autonomic nervous system controls the heart. And I'm going to talk about the role of the autonomic nervous system in disease and sport recovery. Then we'll move into some quantitative autonomic markers, which is heart rate variability or HRV. We'll discuss its measurement and also its interpretation, which includes recording of an ECG and its analysis, and how we could interpret that HRV. And then finally, I'm going to discuss a few articles and research studies that have been used regarding HRV, particularly HRV guided training and biofeedback. And then we'll close out with questions. So quiz to start. True or false, low heart variability is a good thing. So I'd like you to just kind of write down your answer right now and kind of slide it to the side. And hopefully by the end of this presentation, you know what the answer to this question is. So while the heart is intrinsically regulated, it's its own pacemaker, it is extrinsically controlled by the autonomic nervous system. And the autonomic nervous system is divided into two arms, the parasympathetic or the vagal division and the sympathetic division. At rest, the parasympathetic or the vagal system typically dominates, especially in a young, healthy individual. But anytime a stressor is introduced to the body or the system, it results in immediate vagal withdrawal and increases in sympathetic nerve activity. And this is a normal response, especially in terms of exercise. The autonomic nervous system couples with the cardiovascular system to help meet exercise demand by increasing things like heart rate, blood pressure, and vasoconstriction. And these are all important because they help drive blood flow to the active muscle. But while we know that these changes happen during exercise, it's not exactly clear how long these changes last, and if these are reduced, should we care? We might want to care because studies have suggested that reductions in vagal tone and increases in resting sympathetic activity might increase the risk of an arrhythmia and also all-cause mortality. And while this isn't likely to happen in a young, healthy individual, we're not really sure if those changes that occur during exercise are in fact negative, or if these short-term effects could cause chronic changes over time. But I just kind of want to heighten the fact that in healthy individuals, it's very unlikely that they might have an increased risk of an arrhythmia that's exercise induced. But it's important to realize that changes in control of these systems could affect things like performance, cognition, and also the emotional health of the athlete. So kind of going from a sport performance standpoint, higher vagal activity is typically correlated with larger measures of aerobic capacity in sedentary individuals and also athletes. So that means they are more aerobically fit. We've also seen that lower vagal activity has been reported in those who have anxiety, depression, and also post-traumatic stress disorder or PTSD. And finally, following things like concussion, we've seen that vagal tone is significantly reduced. And it's likely that this is apparent in things like long-term concussions, and this might be to this uncoupling within the nervous system. So if changes in autonomic nervous system control are important, how could we measure these changes? And for that, we use heart rate variability. So it's a quantitative marker of the autonomic nervous system. And HRV is defined as the oscillations in the heart rate and the R to R interval between consecutive heartbeats. So this ECG strip down here is showing that QRS complex and this R interval versus this R interval, and the time in between here is, in a sense, heart rate variability. So how do we measure, or how do we begin heart rate variability assessment? So the standards for assessing heart variability are put forth by task force. So again, any standard measurement should come from this position stand, but at its basic form, all you need to have is an ECG recording. So we need this in order to determine the HRV. And from a laboratory standpoint, we typically do this with a 3-lead, 12-lead electrode configuration, but really the ECG recording could be obtained with a single or a multi-lead. And recently, and over the past decade, we've kind of seen a lot of different devices that have come out that actually record the ECG. There is single lead ECG patches. There are the polar heart rate chest straps. There are smart watches like the Apple Watch that are now capable of assessing the ECG. And also some clothing and shoe sensors are also able to obtain an ECG signal. And anytime you're recording the ECG, you're going to want to record it for at least a 5-minute duration. And this seems to be pretty standard. So the analysis portion, the analysis portion of the ECG can be really complicated, and it requires a lot of technical training. But thankfully, there's a lot of apps that are now available that perform these functions automatically. And some of these apps include Kubios and Elite HRV. So I'd like to kind of just take some time to explore each of these two apps, which are free and available for Apple and also Android devices. Again, there are a lot of other apps that are out there. However, I happen to know that these are validated apps. So hopefully my video works okay. I'm just gonna show you it from the view of the application on my phone. I have the general steps that are kind of listed over here on the left. But after you download the app, the first thing that you'll do is you'll create a profile. It takes some demographic information, whether you're male or female. It calculates your heart rate max. You insert your height and your weight. You also need to add a heart rate sensor. So this needs to be a Bluetooth device in order to connect to the application. And then you'll want to go into the settings and adjust the duration of the ECG recording. And again, I'm suggesting that you always take a 5-minute recording to obtain the best information from your measure. After you have set everything up in the application, you're ready to begin a HRV measurement. And before you start the measurement, you're going to want to choose a body position to start in. So either a supine or a seated position. You can use both of these positions, but I'm just going to recommend that whichever one you choose, you do this consistently over time, and you always measure it in this position. And also you measure it at approximately the same time per day. So I'm going to just go ahead and show what that measurement looks like here on the right. So I would now just kind of click on this Start New Readiness measurement. It'll kind of start with a 15-second period where you are moving into relaxation. So you can go ahead and move into your desired body position. And then after the 15-second period of relaxation, it will automatically start recording the ECG signal onto the device. And what you're going to see on the screen is it's taking the ECG and it's taking those R-to-R intervals and graphing it in milliseconds over time. So the Elite HRV app is similar, and I'd also like to kind of walk you through these steps in case this is the app that you would so choose. So once again, you would download the application, you would create a profile. It doesn't gather as much demographic information compared to Kubios. It only asks for the birth date and your gender. But after you created the profile, you would go in, add your heart rate sensor, which should be Bluetooth. It'll show that it has paired. And when you go back into the main screen, you would select that plus button in the bottom, and you would start a morning HRV reading. From here, you can go ahead and adjust the duration of your ECG recording. Again, it should be approximately 5 minutes. On here, you can also record the body position that you tested in. And again, that should be the same measurement that you take over time. So now you can go ahead and start the reading, and it will kind of do a similar thing that you saw on the Kubios app, where it takes the R-to-R interval and it graphs it over time. So now I have this ECG. And again, the Kubios and Elite HRV app are going to automatically edit these R-to-R intervals. And so the app does all of this for you, which is really nice. And once it's rejected the R-to-R intervals, what we normally get are all of the R-to-R intervals that we like, which we refer to as the end-to-end intervals, or the normal to normal. And from here, we're able to generate 2 HRV measures in the time and the frequency domain. So I'd like to discuss the time domain methods first. And I want to point out 3 different time domain measures that you should pay attention to if you're using an HRV application. So again, this time domain measure is assessing changes in the time within the R-to-R interval or the end-to-end interval, and also between adjacent end-to-end intervals. So we can get measures like the SDNN, which measures changes in the end-to-end interval, or we can get measures like the RMSSD and the PNN50, which describe differences between the normal to normal intervals over the 5-minute period of the recording. We can also perform additional analysis, such as the spectral density, in order to generate frequency domain measures. And frequency describes how variance changes, or spectral power describes how variance changes as a function of frequency. And those frequencies that you're going to see oscillating in the ECG are low frequency powers, so measures that are fluctuating between 0.04 and 0.15 hertz, and also higher frequency powers where it's oscillating between 0.15 and 0.4 hertz. We can also describe the ratio between these 2 power components, so the LF to the HF ratio. So what do these measures mean? Okay, well, they actually have physiological correlates. So let's just kind of point out the ones that we need to know, and that is the RMSSD and the PNN50, which are time domain measures, and the high frequency power, which is a frequency domain measures. All 3 of these HRV measures have been shown to physiologically originate and are indicative of vagal tone. So if the RMSSD were to increase, this would suggest increases in vagal tone. If the HF power increased, this would suggest increases in vagal tone. And from here, we can assess changes in the autonomic nervous system. So these apps generate measures in the time and frequency domain. And I just kind of like to discuss the Kubios app first. So the Kubios app only generates time domain measures, and specifically, it's only generating this RMSSD. So really kind of what we care about is the measures that actually indicate vagal tone. And again, RMSSD is one of those measures. Again, unfortunately, it doesn't give frequency domain measures, which would be a limitation. This app is also really interesting in that after you perform 5 readings, it will take your HRV measures and compare it to norms, and then put you into a high, low, or a very low category for your HRV. And this can save some time for assessing whether somebody's heart rate variability is good or it's bad. And these are all from reference by Noonan. So the Elite HRV app might be from an advantage because it generates both time and frequency domain measures. So again, you can see here on the left that it does give us the time domain measures, RMSSD, and the PNN50, which indicate vagal tone. And it also gives us the HF power, which also, again, indicates vagal tone. The only limitation that I really see from this app is that it doesn't compare you to population norms. So you would actually have to go into the literature and compare that person in terms of their age and age, sex, and gender to their peers. So it does require just a little bit more work. So over time, you can use these apps to describe what's happening in terms of vagal tone in your athlete, and also trends. The Kubios app is really interesting in that you can actually see trends in history, and it gives you bar graphs over time. So now that we know that we have to have ECG recording, that we can use the apps to kind of dissect this ECG recording, and that we can look for HRV measures that are suggestive of the autonomic nervous system, specifically the parasympathetic. Is there evidence of using this in athletic populations? So I'd like to kind of just begin by describing something that's called HRV Guided Training. And in 2007, Kivamini did this study where they used HRV guided training to determine intensity of endurance exercise over 14 weeks. So 26 healthy, moderately fit males were enrolled in the study, and they put them into one of three groups: a traditional group, an HRV group, and a control group. In the traditional group, they performed exercise in what we would say a linear fashion, so moving from a low to a high intensity. In the HRV group, the intensity that day was dictated by their morning HRV. And then finally, in the control group, they were given nothing. So I'd like to just pay a little bit closer attention to the traditional group and the HRV group, and just give you a general idea of how the prescription was dictated for these two. So after a 5-day rest period, they were given at baseline a VO2 max test. And the VO2 max test was used to prescribe the training load across the exercise prescription. After the VO2 max test was given, they always had a rest day followed by a low and then 2 high days. And then this was repeated once more. After they performed this 3-day split twice, they would have a rest day prior to, again, repeating it twice. Throughout the 14 weeks, they assessed VO2 max every 2 weeks in order to adjust the intensity. So in the HRV group, 10 days prior to the VO2 max test, they asked the subjects to record their HRV for 10 days. And they used this HRV recording to generate measures in the frequency domain, namely the HF power. And they used this to create a reference value. And they used this reference value to adjust the training load, which I'll kind of describe here in a second. But if values were lower than the reference value, they would maybe employ a light or rest day. And if they were above the reference value, they were given a high intensity day. So again, this is illustrated here on these graphs. So again, similar to the traditional group, they performed 5 days of rest prior to the VO2 max, and then had a rest day followed by a low and high day. But on the days following, the intensity of the training session was always determined by the high frequency power compared to the reference value. So just an example, on day 11, the high frequency power had been reduced, so this individual performed low intensity exercise. But on the following day, their HF power was increased past the reference value, so they were asked to perform high intensity exercise. So basically the HF was determined by the reference value, and they might have done more high intensity days or less high intensity days, and this was on a case by case basis. Nevertheless, they always rested on the 9th day. And again, similar to the traditional group, They always retested the VO2 max every 2 weeks to adjust the intensity of the training load. So again, just from a general standpoint, like pictures, they always started with a rest day followed by a low and high day. If their HRV was increased, they got to do a high day. If their HRV was decreased, they got to do a low day. So again, the schematic kind of illustrates the loop of which they performed intensity loads. So what happened? Well, the figure on the left shows that compared to the traditional group, the HRV group actually had a greater increase in running velocity, which was actually a really good thing. However, there wasn't a change in the VO2 peak, which was unfortunate. But we all know that the VO2 max is pretty hard to change, especially in moderate to high fit subjects. But nonetheless, I think this study is really useful in suggesting that HRV guided training could improve performance measures such as running velocity. The second thing that I'd like to discuss is a combination of using HRV and biofeedback. And two populations that this has been used on is concussion and also anxiety and depression. So there is a heart-brain interaction, and according to a really large review that was done by Bishop, traumatic brain injury alters autonomic nervous system function, and what happens is it results in uncoupling. So if we kind of think about if an athlete were to sustain concussion to the prefrontal cortex, that this would have some downstream effects in the brain. And I think that we often think about the concussion being an anatomical injury, but it's a physiological injury. And when damage occurs to the prefrontal cortex, it can disrupt the communication network to the amygdala. And the amygdala regulates behaviors on the hypothalamus and downstream regions such as the autonomic nervous system. And this can cause changes in vascular function, including heart rate and blood pressure, and also some measures of blood flow. And I also think it's important to realize that the more severe the head injury, the greater the uncoupling there is between the autonomic nervous system and the cardiovasculature. So we could say that insult is directly proportional to injury. So is there evidence that individuals who have traumatic brain injury have reductions and changes in the autonomic nervous system? So in 2004, Gall conducted a study where a large league, a junior Pacific league, consisting of about 7 teams, they were recruited for this study. So they had 147 people enrolled in the beginning, and these were high school male hockey players. They followed the 147 people that were enrolled, and over the season, 14 had sustained a concussion. And they were really interested in studying these 14 individuals that sustained the concussion. And what they did is they took their teammates who played similar positions, playing time, age, height, and weight, and they acted as their controls. 2 days approximately after the concussion, they had these individuals, the concussed and the matched controls, come in for a 5-minute ECG sample, and they also filled out a signs and symptoms questionnaire relative to their concussion. They continued to administer the sign and symptoms questionnaire until the athlete was determined to be asymptomatic. And once the athlete was asymptomatic, they gave them an acute exercise bound to perform. And this was on a bike, so cycloergometry, 10 minutes at a moderate pace 80 to 90 RPMs at 1.5 watts per kilogram. And they did this twice. So they did it after the athlete was asymptomatic, and then they repeated this 5 days later. So this was in a 10-day span of time after they had reported that they were asymptomatic. So the top table is showing you the heart rate variability at rest in concussed athletes and their match controls. And you might notice that there's no differences at rest between these two individuals. However, once these individuals started performing exercise, this actually was no longer the case. And what we actually saw was that in the individuals who were concussed, they had actually significant and greater reductions in HF power compared to the matched controls. And what this is showing is that the concussed athletes had less vagal tone after the exercise compared to their healthy controls. So again, this is likely related to their concussion. So there were a couple of really important takeaways from this study. You know, we typically determine return to play by resolution in signs or symptoms, but I think there's a lot of evidence that these might be really poor indicators of underlying cognitive and physiological disturbances. It's important to realize that when we were conducting this study during exercise, the athletes were asymptomatic. So at 10 days post-concussion, vagal tone was decreased in the absence of signs or symptoms. So the question is, you know, how long does recoupling of the autonomic nervous system take place? And no, I don't know the answer to that question, and I don't think that that question has been actually really even looked at yet. But I think it's really important for health and fitness professionals to use HRV as a biomarker in the weeks, 2 months following TBI, to see when these measures actually start to return to normal. So if there's evidence that our concussed athletes have lower HRV, and this could be a bad thing, how could we help our athletes? Well, according to Lair in 2000, HRV can be improved with something called biofeedback. So HRV biofeedback involves performing these slow breathing maneuvers that are typically around 6 breaths per minute. And the goal is to maximize oscillations in the heart rate. So you're trying to induce the most vagal tone as you can on the sinus node. And we call this breathing resonance breathing. And interestingly, you can actually do HRV biofeedback using the Elite HRV app. So I'd like to kind of show you that first in the app. So I'm going to go ahead and play this here on the, this one first. So this one on the right kind of just takes you through the app. You would click on resonance. You can adjust the duration of how long you want to do these breathing maneuvers for. In the literature, most of this biofeedback has been done over a 20-minute period. And again, similar to when we're taking HRV measurements, you would want to be in either the supine or the seated position, but maintain that position over time. So once you have your chest strap on and you're ready to start your breathing cycles, it kind of looks like this on the screen, where it's prompting you to take inhalations and also exhalations too. And again, what it's trying to do is it's trying to maximize the HRV with your breathing. And over time, the app is actually able to identify the breathing frequency that can give you the greatest increase in the HRV. And for some individuals, that might be 6 breaths per minute, and for others, it could be as little as 4. So this Elite HRV app Again, it uses the resonance breathing, and that was actually developed by Dr. Lagos. And I'd like to share a study that she had done in 2013. And I'd like to just proceed that this study was in fact very novel. It was a case study report of a 42-year-old woman who had reported post-concussion syndrome. Post-concussion syndrome is when you have 2 to 3 of the symptoms that last longer than 3 to 6 weeks. So her PCP actually referred her to Dr. Lagos for this HRV biofeedback training. And while she was doing this training for 10 weeks at 6 breaths per minute, that was her resonance frequency, they were assessing changes in her post-concussion symptoms and also her HRV. So one of the questionnaires that they used to assess whether this biofeedback was working on this individual was the River-Mead Concussion Questionnaire, or the RPQ, which asked the individual to rate the severity of their concussion symptoms. And you can see that on the first session, this was actually really high. She was at 57. And this, again, trends downwards over the weeks. And you can see actually by the last session, so the 10th session, she actually reduced it from 57 to 15. Again, so less severe post-concussion symptoms after this HRV biofeedback training. They also administered a questionnaire that recorded mood disturbances relative to tension, depression, anger, alertness, and in general confusion. And again, you can see at the first session, each of these subscales is quite high. But as these HRV biofeedback sessions go on, we see a reduction in mood disturbances in each of the subscales. And then finally, they also assess the impact of headaches on her daily functioning. And at rest, she was actually like at 68, and a score of 60 is actually considered severe impact on daily functioning. But by the 10th session, so by the 10th week, she actually reported that she had little impact of headaches on daily functioning as a result of the HRV biofeedback training. So post-concussion symptoms and mood seem to have increased, but did this also happen with increases in HRV? That's a little bit unclear in this study because the HRV measures were not well reported. But we did see an increase in one measure that we haven't talked about, and that is the total power. The total power describes the variance of all the end-to-end intervals, and it is a time domain measure. And from kind of just a practical standpoint, if you think about having more variance in the end-to-end intervals, this might be indicated of vagal tone. However, there's no evidence for this in the literature, so it's at this point speculation. So I think this was a really great study showing the potential usefulness of using HRV biofeedback in those with concussion, but we probably need a more well-controlled study and reporting of HRV measures to understand this relationship. So could we use biofeedback training for anything else? And that's what Paul investigated in 2012. In this study, they had college-age men and women basketball players who reported a history of anxiety via the State and Trait Anxiety Index. So they all scored above a score of 20. And of these individuals, they put them into 3 groups. They put them into an experimental group who performed HRV biofeedback for 20 minutes per day at resonance, which was approximately 6 breaths per minute. A placebo that just watched motivational basketball videos for 10 minutes per day, and then a control group that received no intervention. In each of these 3 groups, they assess HRV at baseline, 10 days later, and then also follow up 1 month later. They also assess things such as the State and Trait Anxiety score and some performance measures, which including dribbling, shooting, and passing. So what happened across these three groups from pre to post period in terms of measures of anxiety? Well, if you look at these tables, you can see that the only group that had a reduction in anxiety was the experimental group, right? So the group that was performing HRV biofeedback training. And it seems like it reduced by about 20 minutes in, or by 20 points in each of these different subscale measures. They were also able to maintain lower anxiety scores 1 month later into the follow-up period. There were also changes in the groups according to performance measures. And the performance measures, again, were dribbling, passing, and shooting. And I'll just kind of briefly describe these. In the dribbling, they had cones set up, and they would dribble in and out of the cones for 30 seconds. And if they're able to successfully go through the cones, they got a point. And the passing was 3 different targets set up, low, medium, and high from the wall. And they would alternate going low, medium, and high for 30 seconds, as many times as they could hit inside the target within that time frame. And then finally, they did a shooting drill where they were placed at the 3-point line, and they had to shoot. And if they made it, they got a point, and they would have to retrieve their ball and shoot again. And this was performed for 90 seconds. And you can see that from pre to post in the experimental and the placebo group, we did have increases in performance measures across the groups. However, if you look at the magnitude of change in dribbling, passing, and shooting between the experimental and the placebo groups, you'll notice that the magnitude was greater in the experimental group compared to the placebo, and this was significant. So again, this is suggesting that maybe the HRV biofeedback is resulting in greater changes in performance. So we had better reductions in anxiety, greater increases in performance using biofeedback. What about HRV? So again, across the 3 groups, we saw an increase in HRV, which was demonstrated by an increase in the HF power. So pretty happy about that, that it went up, showing that they actually have more vagal tone as a result of this intervention. And although they didn't perform correlations, we might attribute these changes in performance and anxiety to more vagal tone in these individuals. So in summary, I'd like to go back to my starting quiz question. True or false, low heart variability is a good thing? Okay, then yes, that should be false. Okay, we want to have high heart rate variability, right? That is a good thing. So the autonomic nervous system extrinsically regulates the heart. At rest, the vagal division dominates, but at rest, there is changes in balance between these 2 systems, and sympathetic activity increases. Reductions in sympathetic activity, increases in sympathetic activity occur with stressors such as exercise and also injuries such as concussion. And we could assess changes in the autonomic nervous system using HRV, specifically measures like the HF power, the RMSSD, and the PNN50, which are all physiologically indicative of vagal tone. So we can use HRV to assess recovery, injury severity, uncoupling, anxiety in our athletes. So my take-home message is this. Given the widespread availability of devices capable of assessing ECG, you as an athletic trainer and health professional should incorporate this tool. Again, the goal is to improve the health, performance, and recovery of athletes, and also return time to play. I'd like to thank Michelle and everybody at Relevate for having me here. And I'd like to invite any questions that you might have this time.
Awesome. Well, thank you so much. And as we wait for some of those questions to come in, I wanted to pose out there to you. You had talked about a very low, and then I don't remember if you had said high or normal heart rate variability values. Are there standard values to look at, or is it something that's specific to the person and how they're changing over time?
So we have reference values for different populations and age and sex. And I'm going to try, and that was described by Noonan in 2010. So they actually have a lot of reference values in that article that you can pull from. The Kubios does that automatically. So after 5 days, it will compare you to all of those reference values from Noonan. I hope I answered your question.
Okay, so the first question, another question here comes from Philip, and he asks, have there been any problems with teams buying into utilizing heart rate variability in training programs from your experience?
I haven't heard of teams using HRV guided training because it is so new. And I'm just not aware of the fact that people know how to use this for athletes. This Kivamini article that came out is probably one of the first ones, and there's still a lot of evidence that HRV guided training could be useful for endurance exercise. We haven't seen a lot of the effects of using HRV guided training for anaerobic exercise, though.
Yeah, and I would add just a little bit to that. And you and I had talked about that before we started, that UFC has started using heart rate variability in terms of their training, particularly with their post-concussive protocols. And so they are following for some improvement with the heart rate variability markers as they're going through the rehabilitation process. So that could be one area that some people are using it for application. And Mike asks, or it might be Michael or Michael maybe, with the VO2 max study that you had talked about at first, for the 10-day heart rate variability baseline, did they perform no activity, or did they, oh yes, okay, thank you, it is Michael. Sorry about that. Did they perform no activity or their normal workout regimen?
It wasn't explicit in that. I would assume they asked them to do their normal activity, and they would ask them to assess their HRV in the morning before they did anything. So again, the article didn't say what they did in that 10-day period prior to my knowledge. But that would be a good question because that might have influenced the reference value.
Well, while we wait for any of the other questions to come in, and we'll go ahead and
So you said UFC was doing HRV?
Yeah, so UFC is using the Aura Ring now as part of their post-concussion protocols. And then you and I had talked about how there are some other professional teams there with the LPGA, and some of the NWSL for soccer teams are utilizing the Whoop band. And so they're with those, both of those typically measure their sleep value and determine heart rate variability while they're sleeping. And then they have an activity component that measures the exercise loading. And so part of that question that I wonder if Philip was kind of alluding to is if you have someone who maybe to them a workout was a very strenuous workout, they have a high load, now they have changes in terms of their heart rate variability, and they should be on a rest day, and everybody else on the team should be on a high intensity day. If you have maybe a misalignment of some of the players, you might have changes there. And kind of maybe that another contributor might be the correlation with like poor sleep into heart rate variability amounts. Yeah. And so if they're having this big change, they might follow it if the teams are flying across the country for an event, and if they are noticing, okay, we have had a significant drop in everybody's heart rate variability, let's go ahead and have a recovery day. But I haven't actually been, in the process of utilizing that.
Yeah, I think it would definitely be weird to have like people doing high and low intensity days, so they're like not like, doing the exercise as a team. I think that's what you're saying, right? Okay.
Like if you and I went and did the same workout, you might have less of a drop in your heart rate variability, and I might have a significant drop in my heart rate variability. And so if they were to, if a team was to be buying into this and then utilizing it directly to help drive exercise programs, he was asking, are there any problems with teams utilizing heart rate variability? And I would think, well, if you're going directly off of that, and some, like one athlete has a really low amount, and you're like, okay, well, this person needs to have a recovery day, but everybody else doesn't. You could have the schedule misalignment of people.
Yeah, I agree. It gets like kind of tricky, but it's like you have to it's a double-edged sword, because what we've seen is that in training programs, everybody responds differently. And if you want the athlete to be the best athlete they can, there's no one-size-fits-all principle. So I think this would be a sacrifice that you would have to make. And I think that it would lead to better long-term changes.
And maybe better for an individual sport versus a team-based sport.
Yeah, maybe, better, because it might be just, again, it might be kind of just odd to have everybody on different scales or different schedules. It might be hard for the strength coach to, but yes, you're right.
All right, well, great. I know I was looking to see, we had around 90 people here today, so thank you everyone for coming. This is a great talk. If you have any other questions, please don't hesitate to reach out. We can always pass those questions along to Erica. But thank you, and thank you, Erica, for a great presentation. Always good to have new information presented. So really appreciate that. All right. So I hope everyone has a great night.
I'll see you later. Do you want me to sign up? Do I stay on here? Are there more questions? I can stick around. I'm not doing anything.
Yep, I'll go ahead. I'm going to stop the recording. Yep, we got lots and lots of thank yous. Okay.